Hi, good afternoon. Thank you for coming, and happy to see all of you here. So we just want to talk briefly about the relation of hepatitis B and liver cancer. Let's see. Okay, so as what Dr. Park talked about, that hepatitis B is an endemic disease in the country, right? So if you look at the patients infected with hepatitis B, which is manifested here, where red is like really bad, right? So white is good, red is bad. If you look at the incidence of liver cancer on the right side, there are a couple overlaps, right? Such as in Asia, there's a lot of overlap. Africa, Asia, there's a lot of overlap, indicating that actually when patients infected with hepatitis B, the incidence of liver cancer also increases. So in fact, Africa has the highest endemic hepatitis B. And the countries with the largest number of patients with hepatitis B by order is China, India, and Nigeria. In fact, in China, there are about close to 95 million people living with hepatitis B.
Don't still pick up. If you get too close, it actually gets distorted.
Oh, okay. So in New York City, where we live right now, liver cancer is the second leading cause of cancer-related mortality in Chinese men, and the third leading cause of cancer-related mortality in Korean men. So even in the US, in New York City, it's still a very deadly disease. Okay, so when did we first find out that hepatitis B actually increased risk of liver cancer? That was in 1981, right? So that's almost 40 years ago. That there's a study done that indicating that for anyone who's infected with hepatitis B, there's more than 60-fold of risk to develop liver cancer, very high. So there are additional risk factors to increase the risk of liver cancer for anyone who's infected with hepatitis B. For instance, drinking alcohol, family history of liver cancer, co-infection with hepatitis C, actually with HIV as well. So all these are factors that increase the chance for liver cancer development if someone's infected with hepatitis B. There's some additional risk factors we want to talk about. So for anyone who's a carrier, so as what Dr. Park explained, the carrier is anyone who has hepatitis B for about 6 months or longer. 25% of those patients will eventually develop liver cancer. So in those carriers, 30 times risk to develop liver cancer compared to any other people who are not carriers. And most of the liver cancer occur in patients who actually have cirrhosis. But even for patients without cirrhosis, there's still a risk for liver cancer. So when Dr. Park showed a picture earlier, he actually discussed some blood markers, right? One of them is surface antigen. The other one is E antigen. So when we check for hepatitis B, those are the two blood tests we usually order. If a patient has both surface antigen and E antigen, then the incidence of liver cancer is much higher. If a patient does not have surface antigen, the incidence is still there. It's actually the lowest, but every 100,000 patients, 39 patients will develop liver cancer. So the other risk factor is how active the virus is, right? So the more active it is, the higher chance for liver cancer. For instance, if a patient is positive for both surface antigen and E antigen, the possibility to develop liver cancer is over 1,000 people, every 100,000 per year. And when a patient does not have E antigen positive, the risk decreased by 3-fold. And then we discussed earlier, when surface antigen is negative, the risk again decreased by 10-fold. But either way, there's a risk, but we know that hepatitis surface antigen indicates that the virus is replicating. Hepatitis E antigen means that the virus is highly infectious. Not only it replicates, but extremely infectious. Okay, So another way to look at it is that if you have a patient, man, because liver cancer occurs more commonly in men than women, if this person has both surface antigen we discussed earlier, which is a sign of replication, meaning the virus divides, and E antigen, which means that the virus is highly infectious, compared to someone who has only surface antigen, which means that the virus replicates and divides, but not highly infectious, the risk is 60 versus 10 times risk for liver cancer. So this is just a picture, right? So there was a study looking at the amount of virus in the blood we call viral load. So basically the blue one, which is less than 300 copies per ml, per cc, and that has the lowest risk to develop liver cancer, right? So the y-axis, the incidence of liver cancer. If, however, a patient's viral load, meaning how much virus in the blood per ml, is over 1 million, which is red, then the risk of liver cancer is much higher, right? So you see that here in patients on the left side, when the patient has a risk for liver cancer, on the right side is a risk for cirrhosis, right? So basically, if a patient has high viral load from hepatitis B, it's a higher chance to develop cirrhosis, which is loss of function of liver, and a higher chance of liver cancer. So this is just a picture looking at the fact that if you have a patient whose viral load is very low, meaning less than 300 per cc, which is measured by this very purple color, the risk of liver cancer is relatively low. It's less than 1% per year. But if a patient has a very high viral load, right, which is more than 1 million here, manifested by the red color line here, then the risk of liver cancer is high to begin with, and it increases as the time goes on, right? So if you buy 10 years over here, it's about 10%. So meaning 100 patients, 10 of them will have liver cancer by 10 years. Okay, so what happens after patients infected with liver with hepatitis B, right? So Dr. Park reviewed this with us earlier, so I'm going to talk very briefly. So basically, someone's infected with the virus, let's say acute infection, meaning there's acute inflammation of the liver, patient feels very sick, we have nausea, vomiting, our eyes turn red, cannot eat. So that's an acute infection phase, right? So the younger the patient is, the higher rate of infection. So if a baby was born with exposure of hepatitis B, 90% of them develop chronic infection, which is when a mom has hepatitis B, give a birth to a baby, and the baby was never given any medication before the baby was born, this baby's risk of acquiring chronic infection 90%. But as an adult, any one of us, if we are exposed to the virus, then the chronic risk is 1%. Chronic meaning more than 6 months with the virus. And then after acute infection, right, there's a clearing phase, which means that some of the liver enzymes, right, is increased, and the viral load, which means the amount of virus, is relatively high, and the E antigen, which is how infectious the virus is also positive, right? So during this phase, the treatment for hepatitis B is highly recommended, right? Because those patients in this phase, meaning they are, number one, they have very actively dividing virus that's highly infectious. And the liver is undergoing a lot of inflammation. So the risk of chronic infection in the future is very high, and the risk of cirrhosis and liver cancer is also very high. Then it comes to a third phase, which is called active carrier phase, where the patient would have this marker for virus to divide, but the infectious ability is much, much lower, right? Because in the second phase, that's when infection is very high potential. And the liver test, such as ALT, is actually normalized now. It was elevated before, not normalized. However, so on the surface, it looks okay, it looks better. But at this time, cirrhosis may have already occurred. So that's why we wanted to make sure in the second phase that we recommend that patients seek medical attention if they indeed in this phase that antiviral medication is initiated, right? And the last one, which is the ones that we do not want to see, is called reactivation phase, right? So reactivation means that even though the infectious ability is supposed to be negative, and patients supposed to already have antibody against this E antigen, which means that they've had a phase where the infectibility is very high. Eventually, this phase disappears, and patients should have less infectious virus in their body. But the viral load can be small, but we can still detect them, which means if we do a blood test, it's still there. And the liver test will start to become a little higher. During this phase, it's actually very dangerous, right? Because at this phase, the mutations occur. So basically what happens is that any of our cells in our body can mutate, which means can spontaneously change its genetic materials. What causes that change? One of them is chronic inflammation. So when we have a virus integrating into our DNA, like what Dr. Park explained, it causes chronic inflammation. So that would lead to mutation, which would be very dangerous, right? Because what happens with constant mutation is eventually bad things happen, lesions occur, and it's actually precancerous, right? Which means that cancer will eventually develop in those situations. So that's the 4 phases of hepatitis B infection. Someone only get acute infection, but never got a chronic infection. But if you go to the second phase, just remember this is a very dangerous situation. We need to have antiviral treatment. Once we go to the third phase, cirrhosis may have already developed, even though we may look okay, we may feel okay. And the last phase is when it becomes really dangerous, right? Because there's a risk of liver cancer at that time. So as Dr. Park explained, there's a vaccine for hepatitis B. So how do we prevent liver cancer from hepatitis B? Is we need to start from the beginning, which is we have vaccinations, right? So there was a study did in Taiwan, which actually was endemic with hepatitis B infection before vaccination was instituted, right? So in 1984, a nationwide vaccination was a policy for everyone there. And you see actually what happened is that 10 years later in 1990s, the children's incidence from liver cancer dropped dramatically, right, by 50%. And also kids that die from liver cancer also drop by 50%, which means vaccination of hepatitis B is the most effective way reducing hepatitis B related liver cancer. So that's why many countries, including US, once the baby is born, automatically the pediatrician will say, let's try to have hepatitis B vaccination, okay? So that's very effective. So let's talk about diagnosis, right? How do we diagnose liver cancer? So we may have some symptoms, right? So symptoms are very non-specific. Fatigue, I'm feeling tired. I may have weight loss, but I may have pain, but those are non-specific. If a patient has a risk factor, which means patient has a reason to develop liver cancer, such as hepatitis B, if you have a blood marker that's low, it's called AFP, then if you do an imaging study with either a CT or MRI, 2 cm or higher, 2 centimeters spot in the liver, then all you need is a scan that's showing that it has a lot of blood vessel in that particular lesion to tell you this is a liver cancer. If the patient's blood marker AFP is high, more than 200, then you just have one modality, either CT or MRI. That's all you need to say, well, this spot is liver cancer. So you do not need a biopsy, right? So this is very different from many cancers. Liver cancer, a lot of patients are diagnosed without a biopsy. If a patient already has a cirrhosis already, right, for whatever reason, maybe alcohol, maybe obesity, or maybe hepatitis B, whatever that might be, you need to look at the imaging studies. And same thing, right? If it's 2 cm or higher, it will show you some interesting features there, and then you do not need a biopsy. Obviously, the other way to diagnose is to take a piece from the spot of the lesion in the imaging studies and give you a pathological diagnosis. So how do we figure out where we are, right? If a patient diagnosed with liver cancer, is it early, is it intermediate in the middle, or is it late, right? So the early part here, this is a system based on liver cancer developed in Italy. So basically, there's only one liver cancer here, and the other parameters look okay, which means we do not have a lot of pressure in our body. Our liver tests look good. Then people go for resection, which means complete removal of the tumor from the liver. And people who can do that is about 10%. If you have 100 patients with liver cancer diagnosed, 10 of them would have this opportunity to have a resection. If it's more than one spot, say 3 spots, there's no disease related to the liver cancer at that time, which means liver tests looked okay, not too bad, then people can go for transplantation, right? So how many patients are eligible for transplantation? 15%. 100 patients, 15 of them may be eligible for transplantation. All the other patients, we can give some injection or burning, called ablation, so that we use microwave to burn away the tumor in the liver. The effect overall is not as good as removing, which is resection, or transplantation. But overall, in 5 years, 50% of patients will be alive. This is considered curative treatment, meaning we're trying to treat the cancer with intention of getting rid of it completely with a cure. The rest of the patients, unfortunately, we are not able to cure. If we have a patient who has multiple lesions, or they have less than 3 centimeter lesions, but 3 lesions, but some of them are bigger than 3 centimeters, right? So what do we do? We'll do TACE, which is we inject chemotherapy through the artery into the liver, because most of the liver cancer is derived, their nutrition from arteries. And we have another way to supply nutrients to our liver. So that gives us some survival, about 12 months. And if we have patient who, we have multiple liver lesions, we cannot use the therapy through the artery of the liver, we consider them as advanced stage. So the only one approved by the FDA right now is a pill. It's called sorafenib, right? So a patient taking the pill, I have 100 patients, probably 50 of them will have a survival about 11 months. So we don't want to be here. We want to be here if possible. So surveillance is important. That's what we talked about. So this is just a picture showing you how to perform embolization, which is inject chemo into the arteries. Is that, in fact, in liver cancer, right, most of them are supplied by the artery. And normal liver is supplied by vein. So that's different in liver cancer. We have 2 source supply. So basically, if we have TACE, this is the artery, right? The doctor will put a catheter through the artery here, and this yellow spot is where the cancer is, and it will administer, this is part of the area going to the spot with magnifying glass. So the doctor will inject chemotherapy through here into the spot. So the liver cancer, once the chemotherapy reaches the liver cancer basically dies, right? It's a medical term called necrosis, so basically we just kill the tumor dies. But the death is usually transient because we're not able to remove everything completely. It most likely will come back. As we discussed, if we're not able to remove the cancer, we cannot go for transplant, we cannot inject anything into the spot, then the only therapy we have is sorafenib. In liver cancer, it's very important to have a concept of clinical trials because even though sorafenib is what FDA approved for us to use, but considering the efficacy of the drug is very limited, right? Because most people do not live beyond a year, where actually it's important for us to consider clinical trials. So we have a trial open right now for anyone who's diagnosed with liver cancer, cannot go resection, cannot go transplant, cannot have the lesion burned, or cannot have chemo injected into the artery. We have a trial comparing the standard therapy versus new therapies, which have some very encouraging results in earlier studies. So if a patient receives this medication and eventually the cancer stops responding, what do we do afterwards? So we do have second-line options, which means we have FDA-approved medications that can offer to our patients that this is a medication. So sorafenib is a oral medication. Regorafenib is also an oral medication. And another option is actually immunotherapy, which is an intravenous injection for the patient. So that's where we are if we're at the stage where the cancer cannot be removed or partially treated. So what do we do if we have a patient with hepatitis B, right? So Dr. Park said that we really need to do good surveillance. So usually we do it by checking the blood every 6 months for the marker we talked about, AFP. We do some imaging studies, right? So the most common one we use is ultrasound. Sometimes if a patient have family history of liver cancer, a CAT scan or MRI will be a little bit more accurate. Okay. So if we have patients with cirrhosis, the risk of liver cancer is high, right? So it's 3% versus 0.3%. So cirrhosis increases the risk of liver cancer, regardless of whether a patient has hepatitis B or not. So there's a recommendation that anyone who has cirrhosis should have the surveillance, which is every 6 months blood work and ultrasound. If a patient does not have cirrhosis, but if it's a man over age 50 with hepatitis B, even after surface antigen becomes negative, meaning after successful treatment of hepatitis B medications, it's highly recommended that we do surveillance every 6 months. So that's basically the recommendation from the association that studies liver diseases, talking about who should get surveillance in general. So if a patient has liver cancer but it was removed or underwent transplant, what do, right? We actually have to do additional surveillance to see where the cancer is, whether the cancer comes back or not, so we can deal with it as quickly as possible. So usually the oncologist or the transplant surgeon will let you know when to do those, but it's the same AFP, which is a blood marker, and the imaging studies, most often CT scans. There is a very important concept that if a patient has hepatitis B, has liver cancer, had surgery removal or transplantation, what do we do with hepatitis B? We have to continue to treat it, right? Because it's unfortunately not going to be completely cured with any medications. And there is a risk of developing more damage to the liver if hepatitis B is not treated, even after the liver cancer is completely removed. So antiviral therapy for hepatitis B has become very effective. And there is some suggestion that if tolerable, we recommend patients to continue therapy as long as possible for hepatitis B. That's it.